Assalamualaikum warahmatullahi wabarakatuh, and good morning. Thank you very much to Mr. Chairperson for kind introduction. Thank you very much to Department of Anesthesiology and Intensive Care, Hospital Sultanah Nur Zahira, for inviting me to this talk. And I would like to congratulate organizing committee for organizing this I think very important symposium. I think it's quite some time actually for this kind of symposium that we missed because of the COVID. And when we talk about Hospital Sultanah Nur Zahira, it's quite special to me because this is the hospital that first invited me as an AIRWAY speaker 10 years back, 2013. So I started here. So after 10 years, then I came back here. Right. So my topic today is about anticipated difficult AIRWAY in DAYCARE surgery. Is it taboo to dismiss? Meaning that if there is a difficult AIRWAY, should we go or should we not? At first, when I basically got this topic, so the answer was quite clear. The answer is no, right? So difficult AIRWAY is a totally no for ambulatory. But after some time, and then that's the reason why I asked Dr. Hafizi to send my presentation a bit delay because I have to rearrange my slides, and then we look, there are actually possibility. But what I'm going to do today, we're going to look into what kind of the challenges in terms of airway management in ambulatory anesthesia, and also at the same time what the opportunities that we're going to have, right? So basically we have both, but basically of course the challenge is going to be more. Okay, so my presentation will tap up to these the most recent guideline about difficult airway management. Okay, for the past few years, we have all the Airway Society, they come up with the various algorithms. DAS come out in 2020 for awake tracheal intubation, and then followed by Canadian guideline in 2021. And 2022, the ASA guideline that we familiar with. There's a lot of guidelines for the past 2 or 3 years. So what I'm going to do today is basically I'm going to match what we're going to discuss and also with these guidelines. Okay, when I look again into a criteria for ambulatory anesthesia, right? Of course, the keyword here is basically there is a totally no for patient with a history of difficult airway. I think same goes to our country also, right? So basically just about the same. Even though if you look again, there are not many criteria specifically mentioned about difficult airway. Most of the time, the obesity, the ASA guideline, the ASA status, right? All that. But most of the time, because they know that any patient with difficult airway, we won't do it in ambulatory. It's a totally no. Right? So that's the reason why there are not many guidelines come out with the difficult airway in the criteria of patient selection for ambulatory, because it's a totally, we know that difficult airway is a no. Okay, so we look at the incidence of difficult airway, right? So this is the latest one. We have okay, we have a lot of numbers here, so don't worry about that. Basically, what we can learn from the slide is basically, as we manage the patient further and further from the operation theatre, there is high likelihood that you're going to get a difficult airway. Okay, lagi jauh kita manage airway patient daripada operation theatre, lagi senang kita dapat difficult airway. Okay, in ICU, in ambulatory. When you intubate the patient in the ward, I'm sure that any of us here, we have the experience of intubating patient in the ward. Actually, it is even more difficult compared to when you intubate the patient in OT, right? So basically, that's the incidence. Okay. So when you look again, when we do a pre-operative assessment, okay, we do malam pati scoring, we do thermometer distance, and all those tests. The problem with this test is basically, as you can see here, that all the tests are basically basically very low in terms of the sensitivity. Even though the specificity is quite okay, but the sensitivity is quite low. Right? So this is one of the reasons sometimes we miss the patient with difficult airway. Okay, that's the reason also why we combine all the tests. Kita buat banyak-banyak kan. Kalau staff you notice that when you go to with us in pre-operative clinic, then this anesthesia MO or the anesthetist akan buat macam-macam. Barometer distance, malam pati lah, measure the neck dan sebagainya. So the reason being is because we want to increase the specificity and also we want to increase the sensitivity. But having said that, sometimes we still miss this kind of patient. Okay, so when you talk about airway challenges, most of the time we divide the way we think, we divide into three groups, three big groups. Number one, what we call as anatomical difficulties, right? So number two is physiological difficulties, and the last one is the contextual. Okay, so what is the anatomical difficulties? This one yang kita buat tu lah. Malam pati scoring, barometer distance, you measure all everything in the face that you can measure, you measure. So that one is basically for, we want to know anatomically whether the patient is going to have a difficult with mask ventilation, supraglottic airway insertion, tracheal intubation, radiolarynxoscopy, or even FONA, front of non-access airway or surgical airway. But another factor that you need to consider is the physiological as well, right? So physiological, whether your patient can tolerate the apnea tak. So when we want to manage the airway, difficult airway particularly, you want to know whether your patient can tolerate the period of apnea, how long. If you pre-oxygenate the normal patient, they can tolerate the apnea up to 7 minutes. But in the certain patient, COPD patient, dia tak boleh buat. So how you want to manage them? Okay, so another one is risk of aspiration, trauma patient, obese patient, okay. And the last one, hemodynamic instability. This one is basically patient in ICU. You intubate patient and straight away patient collapse. Right. So sometimes that one also is part of the difficult airway because you cannot induce the patient, you induce patient collapse, but now you need to manage the airway. So turn out to be that one also difficult. Okay, the last one, this is what we call as the contextual. Alright, this come the ambulatory adverse location, kan? Kadang-kadang kita jauh daripada orang lain. Satu OT semua dekat bangunan lain, kita dekat bangunan lain. And then you have no backup. You are there with one specialist or sometimes you are alone, right? Airway manager inexperience, lack of equipment, all the best equipment semua duduk dekat OT. So dekat ambulatory care selalunya tinggal larynxoscope saja. So that's also a problem. Team inexperience and also a poor team communication. So when we have this patient with this difficult airway, most of the time we try to look into these difficulties, these three. Right. Again, when you talk about difficulty, if you look again into the current algorithm, what they want us to do is basically, number one, you know then when the airway going to be difficult. Okay, kita dah boleh tahu dah. Okay, number two, you know when you going to fail. Bukan setakat kita akan susah, kita kena tahu juga bila airway itu akan jadi memang langsung tak boleh nak manage, or we call it as a fail airway. The last one is kita nak tahu when you are successful. The current standard, you need to use the anti-capnography. But the most important in this slide is basically we need to beware about what we call as a composite airway failure. Okay, what does it mean? Meaning that if your patient basically going to fail in the mask ventilation, there is a possibility your patient going to fail also in the tracheal intubation, because the criteria for these two just sometimes overlapping. Okay, so we try mask ventilate, there is possibility that your patient going to fail also in the tracheal intubation. So this is the most dangerous part of the difficult airway, because you also have what we call as a composite airway failure. Right? Okay. When you look again into the old records about airway, if you look into the US database, they don't have the OD, but what they have is basically what the patient claim. Kan kalau katakan patient tu come for anesthesia and suddenly pass away, then they claim and they bring the case to the court, so they make it as a data. So what we worry is basically most of the time the patient who fail to manage the airway, most of the time they die, or they have a permanent brain damage because of it. Okay, so this data is basically from 85 to 99. Okay, and again you can see the total number is okay, but you can see that incidence of the brain damage and also death more than 80%. Right? If we fail to manage the AV. Okay? Right. So this one, the latest one, they look into the case yang pergi court daripada tahun 99 hingga ke 2012. So tadi tu 85 99. This one 99 to 2012. You can see that the incidence of the death and permanent brain damage still very much high if you fail to manage the airway. So despite all of this technology improvement, of course during this time we don't have a radiolaryngoscope yet, not that many, but the incidence of brain death and permanent brain damage is still high. Okay? Right. Again, sama saja. You can see that death and permanent brain damage is very high. Most of the time approaching 100%. So kalau kita fail to manage the airway, almost 100% patient tu sama ada permanent brain damage or meninggal. So that's the reason. Right. So what happened actually during the OT? What went wrong? So they look through and diorang tengok there is a inappropriate difficult airway management, including failure to use supraglottic airway, perseveration. Perseveration ni meaning that fail intubate lagi, fail intubate lagi. Kita tak move to another technique. Right? Failure to plan, delayed calling for help, inadequate preoperative airway evaluation and all this. Okay? Right. So if you look again into this is what we call as NAP 14. This is a very good NAP 4. This is a very good audit. In the UK, they did this audit nak tengok macam mana anesthetist in the UK manage the airway. Okay? So this is a very comprehensive audit. There are almost 300 pages. So tak perlu baca semua. Baca dia punya conclusion je. So what you can do, what you can see is, okay, the multiple attempt at intubation using a single anesthetic plan were not uncommon. So maksudnya perseveration. NS ni dia suka intubate lagi. That one was a common practice dulu-dulu lah. Right? So the next one you can see, intubation of prior knowledge of difficult intubation was often followed by the IV induction. So we already know that the patient is going to be difficult, but yet you put patient under. Kan? Kita dah tahu difficult airway, nampak ada features, but we try our luck. Just give lah one IV and see how, whether you can intubate the patient or not. Right? So this one reported in 2011. Maybe now the practice is no more there. Right? Okay, so this paper published many years back in 2015. Then you can see here that out of this more than 3,000 difficult intubation, 93% were unanticipated. Walaupun kita dah buat pre-op assessment, tapi 93% is basically unanticipated. Right? So difficult mass ventilation was unanticipated in the almost 94% of the cases. More than 90% tu mass ventilation tu, NS tu tak boleh predict pun. That's what I mean. Okay. Right. So this is another challenge, the obesity. So I think our presenter have clearly indicate about the role of the obesity in the ambulatory. What we worry is basically, kan sekarang McDonald banyak, ada macam-macam So we can see that this is the rate of the obesity in our country. So by 2035, it's going to be about more than about 40%. Right. So obesity also, as you know, that is contribute to the difficult airway. Not only that, so we're going to be the aging nation. Makin lama orang kita makin panjang umur. So meaning that some of the patients might come for ambulatory anesthesia, meaning that there is a possibility this patient also presented with a multiple medical problem, which limit our ability to manage the AIRWAY. Right. So this is the challenge. We are getting older, and our society are getting more bigger. Right. Another challenge for us to manage the AIRWAY in ambulatory is come from this guideline as well. Right. The issue with this guideline, before we start to manage the patient, so you need to answer this question: whether your patient can intubate, can ventilate the patient, whether your patient have high risk of aspiration, or whether your patient is basically have the increased risk of rapid desaturation. The problem with the current guideline and also regulation, if you have any of these, you cannot put patient under GA. You need to manage the AIRWAY awake. The problem is, obviously, you cannot manage the AIRWAY awake in the ambulatory center. Okay? So semua kena ada. Semua yes. Baru you can put patient under anesthesia. If one is no, meaning that you need to go for awake critical intubation. Right? So this is the American guideline. So the Canadian guideline also just about the same. Sama saja, color saja berbeza. But the criteria is basically still very much the same. Meaning that you need to have all this, can intubate, can ventilate, the physiologic issues is okay, contextual issues is okay, then you go for induction anesthesia. You have this one only, then you go for awake critical intubation. Basically, what does it mean? Basically, what they mean is basically they want us to intubate the patient if the patient is difficult while the patient is awake. It's no more trying. So meaning that if this new regulation is quite difficult for us to do in ambulatory care. Right? So this is something that you have to consider. Right. Again, this is from the United States data. You can see that this is basically what kind of or where the ambulatory anesthesia were given. So basically more than 50% in the hospital base and about 42% actually freestanding. This is a standalone center. But as you can see that the risk of the numbers of the ambulatory anesthesia performed outside from the hospital is increasing. This is in the US. In our country, the issue was always about location. Right? So you can see this is the map of Hospital Melaka. Why I put Hospital Melaka? Because I was introduced to the ambulatory services when I did my MO in Hospital Melaka back in 2002. At that point of time, we already have our ambulatory care services. If I'm not mistaken, only one day per week, it was Monday. So Monday kita akan pergi dekat sana buat anesthesia. But as you can see from here, this is the location of the ambulatory center, right? The OT is up there. 98% of the member of the department is here, and you are here. It's very far. If something happen to you, susah orang nak sampai. Kena buka baju, pakai baju balik, masuk balik dalam ambulatory care center, buka baju, pakai baju balik, then attend to you. If you have a difficult AIRWAY, it takes about 10 minutes, right, at least. So this is a problem actually if you want to do a difficult AIRWAY in the ambulatory center, because some of the ambulatory center is away from our main OT. Like for us in Hospital Tuan Pemizan, our ambulatory care center is within the hospital, within the OT compound. So meaning that this problem might be that is not an issue for us. Okay, right. So we can skip that. Another challenges with the ambulatory care is basically about human factor. Lately there are some emphasis about to improve how we go about the human factor when you manage the AIRWAY. So meaning that when we manage the AIRWAY, it's not only about AIRWAY manager experience, it's not only about monitor, it's not only about the equipment you have. I know after COVID-19, all of us have a lot of video laryngoscope, we have a lot of gadgets, and because of the COVID-19, you have extra budget suddenly. But again, we forget about the human factor. Whether your staff nurse or your assistant understand what going to do if there is a difficult airway, right? So as a result, in 2023, they come out with this guidance how you want to go about, or how you want to train your staff to be aware about human factor in the managing anesthesia and also particularly difficult airway. Alright, so we finished with the opportunities, challenges. Now we look into the opportunities. The good thing is now, like I think the presenter before me mentioned, there are a lot of people are doing regional anesthesia nowadays compared during my time. Okay, so as a result, I'm sure we have a lot of ultrasound. There is a more emphasis in our ministry, KKM, to blocks. We have our special program for the regional anesthesia. So I think this is a good way. This is another way to go if you want to do a patient with difficult airway in the ambulatory care. So you can do a regional anesthesia. But of course, this one need to go into detail in terms of the protocol. Okay. And the good thing also, even though the guideline basically is difficult for you to do patient with difficult airway in ambulatory care, but as you can see that there are clear definition when you are in trouble, right? So nowadays we are not only talking about difficult and difficult, you're also talking about when you should fail. So the guideline is very clear when it's difficult, when it's fail. So meaning that if you do something, then you know that this is difficult, and if something happen, you know when it is fail, right? Okay, so the candidate guideline is go even further. They have this long list. What is the criteria of difficulties in the patient according to the what we call as an airway dimension, right? So this is the criteria for difficult mass ventilation. So they have difficult for supraglottic airway insertion, right? So they have this difficulty with laryngoscopy and tracheal intubation. Even with radiolaryngoscope pun dia ada. What is the criteria of the patient? So by having all these features, basically you can anticipate which kind of difficulties you're going to face. Okay, when you're talking about difficult, okay, including the fauna is basically the surgical airway, right? Okay, and other than that, they also emphasize for us to go very detailed about history taking, physical examination. Even nowadays, they advocate us to use laryngoscopy as part of the airway evaluation, right? I know that we don't have this. Our ENT most of the time is this scope belongs to our ENT colleague, but maybe it's time for us to learn it as well. And of course, this is the time of ultrasonography, kan? Semua ultrasoundable. So they also ask us to anticipate the difficult airway using ultrasound. Okay, there are a lot of measurement in which I will discuss it today. This is out of our context today, right? Okay. On top of that, they have a very nice guideline of what you are going to do if anticipated become unanticipated. Okay, and then you can see that the guideline also colorful. It's no longer like before, black and white. So you know that when you are in yellow, you are quite okay. But if you are in red, that you are know that you are in trouble. Okay, basically this one you can must ventilate. This one is cannot ventilate, cannot oxygenate. So what I'm trying to tell you here, when you're managing a difficult airway patient in ambulatory care center, yes, there are a lot of guidelines for you to use. It's up to you. The option is up to you. Tak ada yang bagus, tak ada yang tak bagus. Semua bagus. Tetapi now there are a lot, and you can choose, and they come with something that you can understand very easy, right? Okay, even the American pun last time very black and white. Kan, siapa yang dah lama dekat sini buat anesthesia, you know last time ASA guideline all lines. hitam putih, hitam putih, hitam putih. Nowadays they come up with what they call as infographic, so you can easy to remember, right? So this is the latest one. So you can see there is a non-emergency pathway and this is the emergency pathway. So it's easier for you to manage the patient nowadays. Okay, of course, what my presenter before this said about our AIRWAY equipment. You can see that the performance of the video microscope is very good, whether it is Macintosh or hyperangulated. And supraglottic airway also, about 94% of the successful intubation. And nowadays the advocate is basically to combine between the supraglottic airway and also the flexible scope, right? Even flex scope also, the successful rate is quite good. It's almost 78 to 100%. Okay, right? So basically now the emphasis is to combine the techniques. Either you use supraglottic airway alone, or better if you want to do a flex scope, combine between the supraglottic airway and the flex scope. Okay, the Canadian guideline is even very detailed. Okay, including all the steps you need to do if you have a difficulty with any of the airway device. Okay, they have this. What you want to do if you have a difficult face mask ventilation. Okay, what you want to do if you have a difficult with the supraglottic airway insertion, and including the video laryngoscopy, right? They even have the guideline if let's say you want to extubate a difficult patient. Both guideline, the Canadian guideline and the American guideline. So in terms of guideline, we are quite protected. There is a guideline for us to manage the difficult airway A to Z, from intubate up to extubation. So this is another way that actually you can manage the airway actually away from the operation theatre. Okay, you have the guidelines to follow. Okay, right. And this is one guideline by the Difficult Airway Society. It's published in 2020. How you want to perform awake tracheal intubation, right? Why they produce this guideline is because there are tendency among anesthetists to move away or to avoid awake tracheal intubation when it is needed. So kita tak biasa nak buat patient nampak suffer. So kita lagi suka patient under anesthesia and you manage the airway. But sometimes it is a dangerous practice. So as a result, Difficult Airway Society they come out with the one specific guideline in 2020 how you want to perform a awake tracheal intubation. Okay? This is a very good guideline because you can memorize easy. It's a STOP, STOP. Sedate, topicalize, oxygenate, perform. But the S is always the small capital. If you look into the original document, S2 dia kecil sikit daripada TOP because it is less important, right? Okay, they have including how you want to go about if you have a difficult with the awake tracheal intubation. Okay, another guideline is coming up, which is also you can use in the ambulatory sector. This is one project that what we call as project for universal management of the airways, which is quite, my own opinion, this is quite ironic because those who involved is basically the one who come up with the other guideline. So now they want to come up with the one guideline in addition of the another guideline in order for you not to follow the other guideline. So orang jadi lagi confused. But anyway, we are waiting for the guidelines. Okay. But the good thing about the first publication by them is basically they come up with this one, the guidelines for preventing unrecognized esophageal intubation. Okay, this is a thick article, but they have a very good recommendation here, so you can go through. Alright. So in conclusion, difficult airway, can you do it in ambulatory care? For me, tepuk dada tanya pengalaman. So So there is no cookbook recipe. It's always up to the depends on your location, depends on your skill, depends on the indication, depends what you have. Okay, that's why if you want to manage that, always look into these three considerations. Okay, with that, thank you.